Hi, so this is a little bit of a combo lecture. We're going to start with some quick information about adherence and self-management and how we support that, and then a little bit on talk therapies, ending with a little bit on panic attacks.
So first of all, thinking about what is adherence? Well, is it sort of doing what the treatment provider tells you to do exactly? And I think, a lot of health professionals would prefer this is the way that patients behaved, and it certainly would make life much easier as a healthcare professional. Um, and I think this is sort of a passive idea of adherence. It's very closely related to compliance. Now, this is a pretty old idea, I would say, and this kind of hasn't been proven to work anywhere for anyone, not just for people with mental illness. About 50% of people with chronic illness don't take things exactly, their medications especially as prescribed. So another way, over time, people started really looking into this in the late 1990s, early 2000s. They were like, how do we get people to do this adherence? And so then they started expanding it beyond medication and saying, the WHO said this is about all the things in which ways a person's behavior of taking care of themselves and their health and their illness corresponds with agreed recommendations from a healthcare provider. Now, a key definition here in the WHO definition is this word agreed recommendations. So it isn't that you just do what I tell you to do, it's that we come to some kind of shared agreement about what the approach will be, what will work best for you. And then from there, we encourage adherence with that. That's the idea of the WHO's definition. And we know from research, from talking to people about, hey, how do you take care of yourself and follow, your treatment plan? There's this isn't an all or nothing kind of phenomenon of I do everything as I'm supposed to, or I don't do it at all. It's more likely that it can happen on a spectrum, and it'll vary and be quite fluid over time for people. So we'll see, on one end of this spectrum here, we have total adherence. I do everything my doctor or my nurse tells me to do, and I follow things to a T, like the regiment. And the other end of the spectrum is I don't do it. I really don't do anything. I have my own way of dealing with things. And more likely what you see a lot of is in the middle where you see partial. So I adjust the doses sometimes. Sometimes I skip a pill if I feel a bit fuzzy in the morning. I don't take that pill until later. Sometimes that pill gives me a headache, so I wait until I really have a lot of symptoms until I take it. So that kind of partial adherence, and then which is intentional, and then there's a partial adherence that's not intentional, such as, sometimes I get really busy with my job and I just sometimes forget to take such and such, or I don't eat as well as I know I should for my diabetes or whatever. So the question always is when we start talking about adherence is whose responsibility is it? And this depends on your philosophy of um, what is healthcare and what is the responsibility of health for an individual. Is it always up to the individual to take information and do the best care for themselves as always? Is that the ultimate goal? And then they're ultimately responsible. All we have to do is tell them what to do, and the rest is up to them. Or is there more of a compromise where we say, well, most humans don't really follow all directions all the time. And so it's a responsibility for us to recognize and not expect 100% adherence, but yet to find ways to make people as successful as possible in managing their illness for optimal outcomes, right? And so that's a tension in and how we design the care and how we work with people can reflect how we feel about this question. So what do we know from the research? And this study, this model I'm showing right here, which is the conceptual model for all the factors that can contribute to somebody staying on their meds appropriately, which is considered perfectly, I think, in most definitions of research. This one looked at 102 different conceptual frameworks where people did research and came up on how people take meds and what gets in the way of it, and developed frameworks. These guys took 102 of those frameworks and looked at what were all the factors that seemed to come across. They did identify that most of the time research seems to always focus on patients, and you can see that there was like 102 studies focused on patient factors, but that there are studies that are trying to look at this in a more holistic way, as the WHO has asked us to do. And you can see the range of factors that could get in the way of just taking medication. And often we think medication adherence is the hardest. I would argue it can be difficult and there's access issues, but there's also harder issues with things like lifestyle change when you're working with people with chronic disease. So things like diet change can be even harder. So this shows us that we have, medication factors themselves, the condition that's being treated can interfere. And these are nicely identified on this slide of the types of things and barriers that could come in the way of somebody being able to stay on their medication as prescribed. So it just sort of shows you this is a very complex issue. And so when we're looking at how we support people, we need to recognize this. And so as nurses, when we're doing assessments and we're planning interventions for people who are coming into perhaps a newly diagnosed state of having chronic mental illness, or in a state of trying to manage a chronic mental illness, we need to remember these things and kind of include them in our ongoing assessments, and the ways that we're kind of thinking about what might be helpful for people, rather than only focusing on patient knowledge or patient beliefs about their health, because that could be important, but it would not be the whole picture. So I'm giving you an example, and I've printed this out and posted it separately from the PowerPoint, but this is an example of Jace, who's a 22-year-old male university student who's just kind of woken up after having a manic episode and being brought into the hospital, and then probably being sedated in the emergency room or else on the unit, I can't remember, and kind of waking up and understanding what's going on for him. This would be a very typical presentation for me working in inpatient on a mood disorders clinic, kind of mood disorders unit with bipolar disorder. This would be a pretty common age and stage of life that I would see people often having their first or second manic episode and receiving a diagnosis of bipolar disorder. And so I wanted to use this as an example because this is the kind of person you might see on an inpatient unit or in the community. It wouldn't be unusual either that Jace is going to come to a community mental health clinic and be assigned to a nurse who works there in the clinic, who will sort of provide that ongoing support and counseling and connection, case management kind of work. So I really want you to think about this now, at the beginning of this sort of lecture, to think about like what kinds of changes would Jace need to do to make sure he has a minimal relapse of symptoms. And I know you probably don't know perhaps a lot about bipolar disorder yet, but he can know that he's been prescribed a mood stabilizer that he needs to take, and it's lithium. And you may remember from pharmacology that lithium has, particular effects that require good adherence to not only taking the medication regularly, but to make sure that I'm not having toxic effects from the lithium, as well as making sure I'm getting regular blood levels checked. So there's increased sort of monitoring with lithium. And so thinking about that, but also the other things that might change in Jace's life now that he's had this diagnosis of bipolar disorder, things he may need to avoid, and often things that are told to people are things like decreasing your stress levels, getting a regular night's sleep, which can be really fundamental for bipolar disorder. Sleep, making sure that sleep is really good. Avoiding any kind of too many stimulants and drugs and alcohol. Those kinds of things can be harder to maintain yourself with. And we're going to say this all to a 22-year-old university student. And so I want you to think about that and all the things that would have to change. And then think also too, sort of maybe on an individual basis, how Jace might have to accept this diagnosis and the kinds of things that might interfere with that acceptance of a treatment plan, of a new diagnosis, of a mental illness. And as an inpatient nurse, as you get ready to discharge Jace to go home, how would you think about these things and include those in a care plan for discharge? So thinking about discharge planning, what are things that you'd want to make sure that Jace was sort of either educated about or given information about, or other people in Jace's life that you might want to bring in before discharge? And then also as a community mental health nurse who would be receiving Jace, what would you see as the priority in care planning? And I think right away, it's always really easy to say, I really want Jace to stay on his medication and develop good insight into his illness and never get ill again, right? That would be awesome if that was our sort of idea. But realistically, recognizing where Jace is at, I have to sort of think about Jace as someone who's probably going to have to come to terms with this idea of what bipolar is and what it means to have it as a young person. And I think that if I'm being sort of person-centered with Jace, I need to be really recognizing this would be a really big transition time for Jace. And so some of my interventions need to be focused a little bit more on that than just telling him, just take your meds, get your blood checked, be good, go to sleep early. Because if we think about what's going to happen for Jace, and we can think about that, he's our example for anybody we could be talking about. The issue of treatment adherence is often a really tricky one because in mental health specifically, because we know that it increases improved health outcomes, less chance that Jace would have to go back to the hospital or have one of these incidences of becoming manic, getting arrested by the police under the Mental Health Act. That would be good, right? If we could avoid those things. Less chance he would have to take time off school, things like that. More likely he could be gainfully employed, get his education and things like that. So those would be good things. It would also, we know, decrease how badly bipolar disorder affects him, but also hit the risk of suicide and death, even from injury related to mania. So all of these things are really good. But the problem is the treatments also have side effects and indirect and direct costs. And it does require acceptance of a highly stigmatized diagnosis and identity. That's a really hard thing to do when you're 22 and you're trying to figure out who you are, right, as an independent adult. And so recognizing that these are sort of tensions that are going to be present when we're working with Jace would be really important, and to not ignore one or the other. And that's because mental illness is a special kind of chronic illness in the sense that it does have these commonalities with chronic illness in general, but it has unique factors as well. So basically, just in general, on the right-hand side of the slide, chronic illnesses, we always negatively frame people who we consider not to be managing their illness well. They're always talked about as non-compliant patients, and that's never seen as a strength in healthcare systems. When people come in and they have A1Cs really high, or we can tell that they haven't been taking their medication, they're it's quite obvious that they're not following maybe dietary advice. They immediately are having a negative framing, right? We are often in our treatment of chronic illness, we are really always promoting this idea of autonomy and choice, but we only really want it if it's the right choice. We tend to like the choices that agree with the ones that we think that people should make. And we know in general, like I said it previously, 50% of people report adherence to prescribed treatment. And this is self-report, right? So I can guess that that's probably even lower than 50% in real life. Mental illness comes with other factors on top of this. There's legal sanctions possible. So if you don't manage your illness, a chronic mental illness such as bipolar disorder for Jace, there is a risk that you can be brought in under the Mental Health Act for treatment, right? And so that pushes and it sort of enforces a sort of idea of you better take care, you better manage your illness right. But it also positions the management of illness now sort of into a legal standpoint. It's no longer about autonomy and choice, perhaps. It's that you have to do that. And often in mental illness, compared to diabetes, we tend to see that if people aren't adhering to their treatment, we tend to say it's a symptom. We actually have an area in the mental status exam where we would say this is a sign of poor insight, right? Rather than an idea of choice or autonomy, even though I think that we do offer people limited ideas of choice in general, in mental illness, it's far narrower. So if we think about Jace as having a chronic illness, we think about this chronic disease management as about self-management of a chronic illness. And so I kind of like this a little better than the idea of thinking about adherence, and this is kind of where most of our work nowadays, I think things have moved on a bit to self-management. You've probably heard this previously, I imagine, in some other course. It's talked a lot about in relation to diabetes and heart failure and things like that. So this is, Laurie and Holman define it as the active management of individuals of their treatment, symptoms, lifestyle, physical and psychological consequences that are inherent with living with a chronic condition. A very sort of holistic idea. Kate Lorig is a nurse who was one of the original designers of the chronic disease self-management program at Stanford, which is a really famous program, and we use it here in Alberta Health Services and around the world. It's called Living Well with whatever, blank, fill in the blank, disease. And it's a course that people can take in the community. And so they would, and as a nurse working in the community, I would lead that with a layperson with a chronic condition. And then we would have a group of maybe 6 people with chronic illness of a variety of types. Sometimes I'd be teaching a class just for people with diabetes, or I'd be teaching a class for anybody with a chronic condition. So it'd be chronic pain, mental illness, diabetes, and heart failure all in the same room. We think of self-management as both an outcome, I have self-managed, and a process. We realize that self-management is an ongoing process. And of course, as life and bodies change, things change in your self-management of your illness. So similar to recovery, what we know is that even though the word self is in self-management, we don't actually think this is just an individual responsibility. Like you just tell people a bunch of information about their illness and then they go ahead and self-manage it. That's not what should happen. I'm not saying it doesn't happen, because I think it does happen quite a bit. It shouldn't happen, because when we look at how successful self-management happens, it's very much a summative effect of the patient, the healthcare team that they're working with, and the system of care that they're in. And all of these things come together to support self-management. So it can't just be the patient. And so if you need to really think about any interventions you're doing, who are you assuming is responsible for that intervention? I mean, it's okay if you distribute ideas, like you do this and I'll do that. But if everything's getting downloaded to the patient or the patient family, then that is not actually good self-management that we're supporting. We're probably setting somebody up to fail. The healthcare provider's responsibilities, if you think about it this way, are things like providing information and check-in points of monitoring signs and symptoms, checking in, is this medication working for you? Being very open with that. A good example in psychiatry, a lot of people, young people, stop taking their medications for a variety of reasons. Sexual side effects are probably number 1, and number 2 is weight gain. And so really asking people, how is it going? Do you like these meds? Do you like how they make you feel? Is it okay? Is it tolerable? If not, what can we do to make sure that it is tolerable? And certainly we've had you have people who have weight gain, immense weight gain from some medications. And so that's not okay to just tell people, well, you're just going to have to deal with it. So really being a provider who's responsive to those kinds of complaints, or recognize that that might not be a tolerable condition. So asking if it's, how it's going, sharing information, especially with decision making. Like you may know this yourself when you've been to a healthcare provider who says to you, well, I've got two options here. Here's like number one, this is what we could do, or number two, what do you think? Right? Provision of support, obviously, finding ways to help people just define what they do and change. And so we know things like motivational interviewing can be really important. Those are techniques not to motivate somebody, but to help people explore what it is they want to change. And so that's a skill that we know if healthcare providers have those skills, they're going to have more productive conversations with people that are supportive. And that you work with a team of people that helps you be more resourceful for your patients, and get more perspectives on things, and staying on top of what is new. We know healthcare providers that are reading the research and listening to what patient groups are saying are probably more likely to help people self-manage effectively. And obviously time can be really important, and being able to have space in our practices to talk to people about how things are going requires that we have more than like 8 minutes to check in with them, right? The patient has a responsibility in self-management, and they obviously have that day-to-day. So Jace would have this day-to-day responsibility, really responsible for showing up for appointments or making phone calls, or at least saying, hey, I'm really having a hard time remembering. Can I get a reminder call or text? Responsibility for knowing what their health history is, and for also staying on top of what's new and bringing that to the team. The system, which is really kind of a key factor in this, and I know this from working in different systems, that it can be easier to support people and harder in others. That, you have to have obviously a group of, you need to work with other people that are on the same page as you as far as supporting self-management. People need access to diagnostic and treatment services. So if I need to have my labs checked every month on lithium, I need access to a lab that lets me pre-book those appointments, that I don't have to kind of go on each time to book and then I can't get one at the right time. And I know this has been an issue for many lab services in Alberta right now, as an example. Systems that allow for shared decision making are really important. There's really cool technological solutions out there that people use in some clinics. Just prior to coming in, I'm thinking of an intervention in the renal dialysis clinic where they have an iPad information gathering piece that patients fill out prior in the waiting room before going in, so that it gathers a lot of their information about how things are going, the side effects, in a way that probably makes it easier for them to tell about them than face to face with the provider. And then that's brought into the appointment so that the provider can see them and say, oh, so I see you're having a really hard time with that medication, or, oh, I noticed that you said sleep is really hard right now. That's shared, that helps with shared decision making. Coordinated care. Obviously, the more people have access to their health records and that those records are accessible to a whole team that might be involved in self-management of chronic illness, because there's often many people involved, that electronic health record can be a really important part. And, and I think the personal electronic health record access is another added benefit for this. And then obviously resources, as we've said, when you need them, that they're there. Okay, so this PowerPoint presentation will be giving you a good overview into just one area of the treatment options that we use within mental health care, and that is around talk therapy. So there are a lot of talk therapies out there. I'm going to go over the two major forms, or I guess three, one really briefly I'm going to talk about, that are used, that sort of are options that patients might be choosing from when they're looking at what works for them. Um, so if we look at the talk therapies, really wide range of approaches, and in fact, probably in Alberta, I would say majority of therapists that are out there, with private practice or even in the public system, our mental health therapists that work with Alberta Health Services, who are RNs, psychologists, and social workers, they tend to use eclectic approaches. You'll see a few practitioners who are pure CBT providers or pure DBT providers, but many people do kind of an eclectic approach of a variety of different types of therapies, depending on what works best for what the client is looking for help with, what their capabilities are, and what kind of matches for them. All of these talk therapies are based around this idea of working through issues and building skills within a therapeutic relationship. The idea being that you do this talking about your emotions or feelings and experiences within a safe space with somebody who's considered you have an alliance with, but isn't somebody it's not a friend, so there's a decreased risk of trying to please that person, maybe. And so that this safe open space provides you a chance to do this work, which you then bring out into the real world of your life. That's the idea. The outcomes from therapy, interestingly enough, despite all these different kinds of therapy, all of the research kind of shows the most important factors for what works best is therapeutic alliance. So how much the client and provider have this bond of working with each other. So often I will say to people who are looking, I don't know if I'm in the right therapy. I don't know if this is the right choice to do. The first question I usually ask is, do you like your therapist? Because honestly, that's what actually matters more than the modality or what the style. And actually, I remember reading this research right after I finished graduate school and I'd done all this intensive training on being a therapist. I was really depressed to read that it really didn't matter as much about the therapist training, educational, discipline level. It was actually more to do with whether there was this alliance and trust between patient and client, and then also, or therapist and client, and then also whether the client felt like they were being helped. So whether they thought that so I might even trust and like my therapist, but then if the homework that they're making me do doesn't seem to match with what my needs are or what I think is helpful, it may not be as effective. And of course, the severity of a client's symptoms. So there's some symptoms that will interfere with the effectiveness of therapy. And so that is where if I'm unable to focus and concentrate because my depression or my anxiety or my mood lability is too much, or if I'm feeling too paranoid to trust anyone, that of course will interfere with the effectiveness of talk therapy. A common limitation of talk therapies is that this is a very Western idea of getting help. It's very individualistic, very much focused on reduction of psychological symptoms has really been the only thing we kind of have been measuring as far as outcomes. So when you look at what's the most effective therapy, often the therapies that are easily measured as far as what are you working, specific skills that are being worked on and can be measured on a tool tend to show up as being the most effective. And so and therapies that maybe perhaps are a little more holistic or global in their effects and harder to research don't show up as effective. So this is a kind of limitation of what's going on. So, often these individualistic, psychologically focused ideas of what's wrong They will work, but they won't capture the collective feelings that might be present culturally too. If I feel like this isn't necessarily my problem, but this is an issue of my community, then talk therapy for one person doesn't really actually kind of make sense, right? So, and Western European styles of implementing this kind of solution, it have been kind of colonial in a lot of ways of taking over other more traditional ways of solving distress. Okay, so the first one I'm going to talk about is solution-focused treatment. I guess it's treatment, not therapy. So this is a really brief therapy approach. Came out, I remember I was in grad school, right, when it first started coming out in the 90s. The idea was, what people started noticing was, you have to kind of understand prior to this. So if you look at the history of the kinds of ways we did talk therapy, going back to Freud and Carl Jung and people like that. So there was very intensive exploration, long standing therapy relationships. Like I had clients in Chicago back in the day that had psychodynamic therapy, like a psychoanalyst. They had a psychoanalyst for 15 years that they saw twice a week. And it was really interesting because I worked in geriatric psychiatry in Chicago at one point, and there was these people would come in because their analyst died. And it was like very traumatic because they'd had this like, twice a week, 15-year relationship with this person, working on their underlying issues, right? So this was a model of therapy that was very intensive, obviously, probably accessible only for those with time and money. And also the premise was that you really had to dig into this deep childhood, issue that was causing the current day problems. So, to counter this, during, some of the shifting of where psychiatry was focusing its efforts, the idea that brief therapy might be more important to just look at, instead of digging in on problems, just focusing on solutions, potential solutions to where things could be in the future, rather than digging in on the past. Which sounds okay. I always have a hard time understanding when they say that something's solution focused but not problem focused, because I don't know how you make solutions without a problem. But anyway, the idea is that people, even though people will have lots of problems, there's usually some aspect or an exception in their life where they manage the problem. So despite feeling incredibly anxious, incredibly paralyzed with fear, people still find a way sometimes to do the basic things in their lives. And that's the piece that this kind of approach says, let's capitalize on what they do rather than what they don't do. So what is it that helps you get out of bed those days when it seems overwhelming? How can we do more of that and less of the lying in bed and not being able to move, right? So this is used in conjunction with lots of approaches. You'll see this very often used in short-term kind of brief interaction points of care. So crisis emerge, this is a common approach where I know I'm only going to see the person once. This can be a very useful tool. And so my job is to find out what's working well. Like, where are these moments where things are, despite all the terrible things that are going on for a person, that they're able to continue on, and how do we make more of that? And what's the hopefulness for the future? And how are we going to get there? It's very sort of positive psychology based. Dialectical behavioral treatment is another kind of talk therapy, behavioral programming. It's a little bit more than talking, actually, because there's a lot of self-monitoring and behavioral sort of intervention that goes along with it. But it is the evidence-based treatment that was developed by Dr. Marcia Linehan, who was a psychologist who was working with people who did a lot of cutting, and sort of developed this technique and it's really widely used for people with borderline personality disorder. Unfortunately, not enough people have access to it. That's one of the problems with it. But it also has been used for other conditions. So you'll see it used a lot for people with depression and anxiety. When I
was in grad school. I got trained from DBT for a couple of years, and we were starting to get hired. This was down in the States. We started to get hired by corporations who just wanted us to teach their staff how to do DBT skills, because the skills component of DBT is it's pretty much like good for everyone. It's life skills. And so basically, this is a form of therapy where you have a therapist, and you have a therapist and a group that you go to, and the group is where you do some skills training and you learn about how new ways of coping with skills. And in the therapy, you're kind of working on more personal things as well as the skills and how you're incorporating them. The theory of DBT is that until you have the skills, there's no point in really digging in on the trauma. And so often it's about a year of skills training before anyone does any sort of more heavy trauma work. This is different than what you'll see with other people who'll just dive right into the childhood trauma work. And I would argue that's kind of dangerous, because sometimes what happens is people just get so dysregulated because they don't really have the skills to manage. And so doing that deep work prematurely can actually cause problems. And the other piece of this is people DBT often comes with some form of crisis support, knowing that there's a lot of times when, especially with borderline personality disorder, people will become sort of really dysregulated and distressed and have extreme responses such as suicidal acts or self-harm. And so when you're in a DBT program, typically you have access to some type of crisis response 24/7. And so when I worked in Chicago, that meant my clients could call me at any time. They actually paged me back then in the old days. So they could page me and I would respond, as long as they had not done any self-harm or suicidal attempts. If they had, they no longer could contact me. And so they would contact me, and then I would be asking them about what coping skill of the skills that they're learning they would be working on. And to be honest, it sounds overwhelming. Everybody always freaks out. They're like, oh my God, your clients can call you anytime. But truthfully, they don't really call you that often, because it just kind of works as just knowing that somebody's there that I could call. And I know if I called them, they would be telling me to use my skills. It sort of contains people a bit. Yeah, and that's pretty much, I think I said everything on the slide. You'll see they'll often have diary cards. That's the only other thing. If you're working with somebody who tells you that they're in DBT, they probably have a diary card where they're documenting what skills they're using when, and you could ask them about that. That's a good cue. So when I'm on the crisis team and I'm working and I see somebody who tells me I'm in DBT, I'll say, well, okay, so what skills are you using right now?
Next, we're going to talk about cognitive behavioral therapy, and I hope you had a chance to read the chapter in the textbook to give you some baseline. So cognitive behavioral therapy is a highly structured, short-term therapy is the idea. It's usually 6 to 10 sessions, although I would say probably, depending on what's been going on for a person, it's not unusual that people would have 15 sessions. It's very structured in the way we usually start with psychoeducation about what the cognitive view of the problem is. So we do a lot of teaching about, number one people that I would see and do cognitive behavioral therapy with would be anxiety, and then depression. It is used, though, for other kinds of psychiatric disorders. You have to be a little bit more specialized to be able to use it. Like, so for people with delusional disorders or psychosis, it can be used, not necessarily acute psychosis, but people with schizophrenia who have some, like, maybe residual auditory hallucinations despite their medication that they're taking. And we can use cognitive behavioral therapy to help them control their response to that stimulus of the auditory hallucination. So it is there. So we start with psychoeducation about whatever the problem is, and we sort of show the client how the cognitive model would view this problem and what we're going to need to build skills around. Then we do a lot of focused skills building, and the skills building is around changing the cognitions, but also managing the emotions that result from the negative cognitions. And so that can be those relaxation skills and ways of kind of mindfulness and staying in the moment rather than trying to avoid, which is a common kind of anxiety response. And CBT always involves lots of homework. And to be honest, and that can be very good because it's very reinforcing, it's structured. You do some teaching in the session, the client goes home with their homework and they come back. So if you're working on an inpatient unit or in an outpatient unit where somebody is doing cognitive therapy, then that's a kind of a nice way to check in on how things are going. How are things going? What are you working on for your homework? And then they can try and show you and practice and ask for feedback on their homework. The downside of homework is this is why cognitive behavioral therapy doesn't always work for some people. Like, for instance, people with attention deficit disorder have a really hard time managing the detailed homework that's involved and will often not do their homework. And so then usually what happens is, they keep coming back. You haven't done any homework. It's really hard to do skills building. And so at that point, it would probably be smarter to change to a different type of modality. Obviously, it requires that you're quite literate and you're capable of writing and reading. We do use this with children, though, usually after about the age of 8. There are some pediatric forms that are sort of developmentally appropriate, using, I think it's Taming Your Dragons is one of the group CBT programs that we use at the Glenrose. And so it's got a nice little story about a dragon and all these kinds of ways of thinking of negative thinking and how to change that. CBT has been very flexible about being adapted. So it was designed initially one-to-one counseling, but it also has been done in group formats and it works quite nicely in group, as well as online modules, which Australia and New Zealand have been really put a lot of effort into designing these kinds of online modules, because some of the stigma of going to a counseling clinic or going to therapy can be overcome when people do the modules. The research initially looks pretty good, actually. It was, again, sad news for me when I found out that I could be replaced by a computer. But for some people, especially with social anxiety, it seemed to be a very important point of access for people, and younger people seem to like the modules. But I think the outcomes right now are equivocal, some improvement with one-to-one, but those online sessions are effective. And you can use these cognitive behavioral strategies. The thing about these things are used not just in psychiatry. So as a person who worked in primary healthcare, we use this a lot in pain management, in diabetes management, any kind of chronic disease management, really. We used a lot of cognitive behavioral strategies, such as symptom tracking, reframing catastrophic pain beliefs. So these were things that you'll see cognitive behavioral strategies throughout all of healthcare.
So when we think about the cognitive model of anxiety, which is what this presentation is really kind of trying to orient you to, is cognitive behavioral treatments, is a common way of thinking about anxiety is to think that a situation makes us anxious. I have a test, therefore I'm anxious. Tests make me anxious. I have test anxiety. That's what it is. And so, and not that test anxiety isn't a real thing. It is, but it isn't actually the test that makes you anxious. What cognitive theorists have done, and this was revolutionary back in 1960 when everything was related to your early childhood development at that time, with Freud kind of dominating the scene of psychopathy. So really, this idea that what could make us anxious was our own thoughts and interpretations of situations. So in the cognitive model, we see this kind of thing happening, that there's actually these automatic thoughts that jump into our head and cause an interpretation of the situation. And it's those automatic thoughts that lead to anxiety. If they're distorted and in any kind of way, they'll lead to kind of a distorted mood, is the way cognitive theorists think about this.
The thing with anxiety is it's the gift that keeps giving. Not only do we have automatic thoughts that interpret a situation and then create anxiety, then anxiety feeds back and becomes part of the situation in which we're trying to cope. And then we then interpret again and create more anxiety. And so, to give you a simple example, if I'm thinking about writing an exam and I'm going to say to myself, I'm going to fail this exam, I'll never pass, this is just another sign of I'm just a failure and I'm going to become homeless and my parents are going to abandon me and this is going to be it for me for the rest of my life. I'll never do anything. So that kind of thinking, which sounds ridiculous out loud, but inside of our heads can be quite believable, are those automatic thoughts. And suddenly I'm anxious, but then I'm back in a situation where I'm writing a test feeling incredibly anxious. So now I'm starting to sweat, I'm feeling dry mouthed, I can't swallow, and I'm starting to feel like my chest is getting tight. And I think I might pass out while I'm writing this test. And then I start to worry about that because then I'm going to interpret that situation. And that's it, maybe would be that I'm not only am I stupid and I'm not going to pass this test and I'm going to be a failure, but I'm also going to make a fool of myself when I pass out or die here in the gymnasium. And so then anxiety goes up even higher. And so this cycle of anxiety is very, very difficult to deal with, and it can escalate very quickly for people. And so when we're working with cognitive model, we're always trying to stop this cycle by helping people, first of all, not only change the automatic thoughts that are triggering the situation in the first place, but also helping them understand anxiety and how it affects their body and how their anxiety symptoms are not actually a threat. They are that's a normal response. It's okay to feel a little dry-mouthed and maybe, a little bit tight-chested while we're sitting down to write a test. Maybe that's okay. If I go to do a presentation and I'm not feeling nervous at all, I know myself, I tend to screw up. So some anxiety is good. And it is normal that I would have some body symptoms of anxiety while I'm doing a public speaking event, right? It's just managing those and keeping them in check that becomes the important part for me, not to eliminate anxiety altogether.
So to start with the automatic thoughts, we're really trying to get people to recognize the distorted nature of those automatic thoughts that are jumping into their head, sort of not at a conscious level, as they interpret the situation. And sometimes we can be just kind of born into this kind of way of thinking, or socialized in, who knows. But or it's something that coincides with the onset of either increasing anxiety and fear or anxiety and depression. And so we start to think this way more commonly when we're feeling that way. We don't actually know. It's kind of a chicken and an egg phenomenon. But we know the more you think this way, the more likely you're going to be having negative emotions. And so these are common unhelpful thinking styles. Everybody uses some of them. And so the idea isn't to worry if you see these definitions on this slide and say, oh my God, I do that all the time. Yeah, you probably do one of these. I'm famous. I like to catastrophize things, blowing things way out of proportion in my head. And all or nothing thinking is a really common one, actually, I find in health professional students and health professions in general. Makes us really good at certain parts of our job, but it can make other parts of our life a little bit more frustrating because things are not one thing or the other. There's a lot of gray in the world, and that can be kind of frustrating. And when we constantly sort of interpret something as one thing, and if it's not perfect, then it's all bad. That can quickly discount any kinds of achievements that we do, right? As an example. So what we're doing with this is we're really educating people about these kinds of thinking styles, telling them that it's common, but that it can have a negative effect on our mood and the way we feel about ourselves and the world, right? And so learning what these are and then learning to recognize them is kind of the basis of what we're doing with cognitive behavioral therapy to start. And then we move into the next slide. So this thought record is kind of the basis of the work early on in cognitive behavioral therapy. Sometimes to start, after I've taught people about what the anxiety model or the depression model of cognitive theory is, I will make sure that they have some skills under their belt around relaxation, deep breathing, some way to manage anxiety, because I know the work we're going to do might create more anxiety or more depressive feelings if they're thinking about having to think about what makes them feel depressed. So I want to make sure that they have some self-management skills for relaxation and soothing under their belt. Then I will start digging in on the thinking. And so often in cognitive therapy, whether that's on you're seeing a group of people doing it or an individual, the work starts with introducing how to reframe thoughts. And so this is a thought record. And you can see, what I would say to somebody is I'd say, can you bring this back to me next week and write down 2 situations. I want you to just notice a time during the week where you were really not feeling good, and that would be kind of related to why they were coming in for treatment. So a time when you felt really depressed, or a time you felt really suicidal, or a time you felt really anxious or having a panic attack. And I want you to do this after the fact, right? I want you to think back. And so I want you to describe the situation. I want you to describe how you were feeling. But then I want you to go back and think in your head, what were the automatic thoughts? What were you thinking that might have been going on that led to those emotions? Then I want you to start thinking about an alternative response, right? And so how you might reframe that automatic thought into something more realistic. The idea is not positive thinking. It's not Oprah Winfrey's just think beautifully. No, it's not that, because the problem with that is if you tell people to just think positive, they're like, yeah, whatever. So the idea is just realistic. So I'll give you an example on the next slide. So if a boss asked me to come in for a meeting and I started to feel I remember feeling really anxious, and I felt just really personally, kind of socially anxious. I was kind of ashamed. I don't know why the boss was asking me to come in for a meeting. So that was a point where I started to get very anxious at work. And so I'd say, well, what was I thinking at the time? Well, I think I was automatically thinking, yeah, I did something wrong. I'm going to get fired. The world has finally figured out that I'm really not qualified for this job. And here it is. It's finally coming out. And so what I ask people to do is I say to them they write all this down, and then I come back to the session with me or to the group, and we say, how believable was that thought? And they say, oh, it was 100% believable at the time. And so when I ask them to think about what they would do to change that thought, what would be a more realistic thought that could interpret the situation that my boss has asked me to come in for a meeting. And that reframed thought might be, I don't know what the meeting is about. I know I am a reliable employee. I might feel like an imposter, but I am reliable at meeting all the expectations. This is what I know. There are many reasons that I could be asked to have a meeting. That's it. It's not, oh, I'm perfect and no one would ever question me. That's not the reframed thought. It's just, there's many reasons to have a meeting. I do my work that I'm supposed to do. I don't actually know what the meeting is about. That's what I know. And you ask people they'll write that down. Initially, they'll tell you, yeah, Holly, that's nice, but I didn't believe it at all. So it's 20% believable. And what I ask them, and sometimes people come back and they're like, I have no idea how to reframe this thought. I don't know what another thought would be. And so we often have to help people. That's why I like group CBT, because it's really nice to get the group working on each other's thoughts. And they can really, and somehow a little bit more believable sometimes too than the therapist coming up with ideas when it comes from other lay people. But anyway, the point being that over time, what you'll see is the believability of the reframed thought starts to slowly increase. And the believability of the automatic thoughts, initial automatic thoughts, starts to decrease. And that's where people start to gain power and awareness over these automatic thoughts. That's really basically how CBT works. So some other CBT kind of strategies that we use and that you could certainly be using within as a nursing intervention with people in psychiatry or mental health settings is monitoring, so symptom monitoring. And so an example for panic disorder would be panic attack monitoring. So but this could easily be transferred to pain monitoring. So it just doesn't matter. Basically, what we're doing with symptom monitoring and tracking strategies is we're trying to get a pattern established. First of all, it's informative to see what's going on, what are triggers, is there a time of day where the symptom is worse? But it also provides a new position of the client to the symptom. And so when someone is having panic attacks, and if you've ever had them, you know, there's a certain sense of being out of control. And that sometimes is actually foundationally more scary than the actual panic attacks. It's just that I have no control over my life. There's this unpredictability, and I can't live with that kind of feeling. So getting people to monitor starts to turn them into their own sort of objective observers of the symptoms, and it changes their relationship. The symptom is no longer running the show as much. They may come out of the blue still, but the person is like studying them, and that objectivity stance that we're trying to put them in helps them disconnect from that powerlessness they have over the symptoms. So that's why it works really well with panic attacks. Honestly, when I would be working community mental health, I would have people referred every week with panic attacks. And the very first thing I would do, because often I would have very long wait lists, and I wouldn't want people with panic attacks to wait long because it's very awful. So I would try to see them within a week or two, if I was lucky, because I would sometimes have 2-month wait lists. And but I would often give them this. I would email them this monitoring sheet with a little reading for them to do about how to monitor and what I needed them to bring to their first session. Often this was enough that people actually started to gain control and didn't need to see me, which was really good. So it can be highly effective. And what is really helpful too is once people start writing down this, the other thing that they see evidence of is the fact that they start to see the patterns of how the symptoms are developing and where and why, but they also start to see that they survive. Because when you're in the middle of a panic attack and you can't breathe and you're feeling kind of shaky and blurred vision and everything else, you think you're going to die. That's a very normal response to those kinds of feelings, or something's really wrong with me. But when you see that that's happened before and you have a piece of paper on your fridge maybe or in your purse that's right there that says, oh yeah, this is actually something that's happened before, and oh my God, it did go away, and oh yeah, now all I have to do is time it. I wonder if this one will last 10 minutes or will it last 5 minutes. That sometimes can be enough to reassure people and start to bring down that panic attack faster. So it also works that way. This would be an example of the calming response. This is something that we would, in the old days, have on a little business card. Now we tend to have like apps, maybe on someone's homepage on their phone, that they can click, and it'll just cue them with this idea that I'm starting to feel increasingly anxious, or and so this was where I just recite this saying, I will not die, I will not faint, I will not lose my mind. This is a panic attack, it will pass. I need to trigger a calming response. And then breathing instructions. So obviously, you don't just hand these out to the general public and say, hey, this will stop your panic attacks. This requires the training of the deep breathing skills and also the psychoeducation about kind of anxiety and the escalation of anxiety and how it works. So this is a tool that people sort of use as they've had, usually I would do this in the part of the psychoeducation of the first session with somebody. Worry time is also a cognitive behavioral strategy. It's a way of kind of thinking about containing the type of worry thinking. So this is really particularly quite good for people who have like generalized anxiety disorder or depression that has a lot of worry, obsession, worry with it. This isn't for obsessive compulsive disorder kind of obsession, but for depression with high anxiety or just plain worry. so what we do, instead of trying to constantly, if you're a worrier, you already know, you spend all your time trying, either worrying or trying not to worry. And so the idea is a lot of that energy when we try not to worry, sometimes that makes us more anxious. But also the worrying itself is very consuming, and negative. It creates a lot of negative emotions. And so the idea, again, is trying to maintain some control over how and when we're letting anxiety drive our thoughts, and when we're and trying to contain that. And so what we ask people to do with worry time is we say, okay, so first of all, I need to make sure that you have some relaxation strategies under your belt, because I'm not going to teach you this unless I know you have that. And then once I know you have that, then I'm going to say, okay, once a day, I want you to pick I want you to pick a regular time every day that you are going to seriously, intentionally worry. And it's going to be for a certain confined period of time, so 30 minutes max, and not right before bed. It needs to be during the day, preferably, but of course, at a time where you actually have time and space to fit it in. And after, I want you to set a timer. I want you to sit down and intentionally say, okay, what am I worried? What do I want to worry about the most right now? And you can do whatever you need to do. You can pace and worry. You can write down all your worried ideas and all the end of the world ideas you have about your worries. And the idea is then you switch. The timer goes off. You switch to a distracting or self-soothing activity, and spend the rest of the day going. Anytime a worry thought comes in, I say, no, you don't have an appointment right now. You have an appointment tomorrow at 10. So that's when I'll think about you. And so every time a thought comes in, I say, no, right on, 10 a.m. You're going to be my number one thought. So the first couple days, it feels a bit fake because obviously you're still having worry thoughts come in. But if you follow through the next day and do your worry time, and the next day do your worry time, what happens is you start to believe yourself, first of all, that you are going to have time to worry. People become very efficient worriers because they realize when they get to their worry time and they're not spending half of it trying to stop the worry thoughts, but just to let themselves worry, what they find is that the worries that seem to be very big don't seem as big. And they actually get some really constructive problem solving or prioritization of worrying happening in that time frame of 30 minutes, and then they switch off. So the control starts to go back to the person rather than the worrying controlling them. Of course, it's really important. You have to follow through, and you can't lie to yourself and say you're going to have a worry time and then not do it, because it won't work that way. So it works really nicely, but again, only for certain types of symptoms. So thought stopping is a technique that we use to, especially when someone has a common obsessive type thought or statement, negative self-talk statement that they say to themselves, that can start a spiral of negative thoughts or mood. And so once people have an awareness of this, what we do is we ask them during a calm time is to just sort of sit and listen for that thought, and then to practice either doing a visual image of a stop sign, saying stop. Turning off a switch is another visual that people will have, paired with a statement such as, I'm not going to think of that, or I am going to stop thinking of that. That's one way of doing it. The other way of doing it is behavioral strategies such as snapping an elastic band. Every time they hear that thought, boom, slap my wrist. Maybe have an alternative statement that we say instead. Some people, to start with, we do this thing where you get people just to sit and listen. I think I've mainly done this with kids. Sit and listen for the thought, the negative thought. If the negative thought comes in my head, I jump up and I say no, and I clap my hands. Now, I don't do that every time I have a negative thought, but the idea is initially I do that, and then I pair it with the stop sign. So no, stop. And then I can just say to myself, stop. And it is enough of a behavioral connection for me to say, think of something else. This works pretty good for some people, some people love it. I've never been able to do this myself, but so I always have a hard time teaching it, to be honest. But I do have clients who love it and it works. It does work well with people who have obsessive compulsive disorder too. They will learn how to do this, as well as people with schizophrenia who will have delusional thoughts that will come into their head as soon as they notice that thought about, as soon as I start thinking about Shania Twain or the Prime Minister or whoever is part of my delusional system, I can do this, and I know I have to stop, and it can stop. When I'm well, I can do that. Yeah.
Okay, and now some just final content for your viewing pleasure on panic attacks. So how do we help people with panic attacks? And first of all, to know that panic attacks can happen to anybody at any time, which is not reassuring, I realize. But so they can kind of happen out of the blue for people, usually in response to a phobic reaction or extreme stress, just out of the blue once. And they also can happen within what we call panic disorder. So panic disorder is usually typically when the panic attacks start to come more frequently, not related to an acute stressor that can be identified. And so that's where it can, and the problem with panic disorder is because the panic attacks start to come more frequently and aren't predictable, like it's not just when I see a spider, it's kind of, I wake up in the middle of the night with a panic attack, that becomes very unpredictable for the person. They start to fear going outside because of the concept of being seen with a panic attack and the uncomfortable feelings that come with it. And so they start to isolate. And so we often describe panic disorder as with or without agoraphobia. So somebody with panic disorder who can still go out and go to work and things doesn't have agoraphobia, but it's not unusual that people do have agoraphobia. So they have panic disorder, they're staying home or avoiding activities. So for instance, exercise is often an activity people avoid when they start to have panic attacks because the feeling of sweat and increased pulse rate can trigger and remind people of the feeling of having a panic attack. So if you've never had a panic attack, lucky you. If you have, please manage yourself while I talk about them, because sometimes, especially if they're a fresh experience for you, which is not unusual in the age group that is predominantly in university, that people are having their very first sort of experience with panic. That as we talk about panic and it's fresh, sometimes that can trigger you to start thinking about your own panic attacks. So, if you've had one and you've tried to manage one, you probably know enough not to listen to this slide, so you can go ahead and skip. So if we think about, for those that don't know, so full panic is a sort of 10 out of 10 on the anxiety scale. It's a very physical feeling as well as mental. So there's racing thoughts and negative thoughts, sense of doom, something bad is about to happen. And then because of the experience of the body, which is generally going into high heart rate, shortness of breath, sweatingness, dry mouth, dizziness or lack of vision, stomach problems, all sorts of things. And to be honest, everybody has a little bit different. Like not everybody has all of those symptoms at once, and people often have their own unique symptoms with their panic attacks. So, but those things start to happen, and then of course they get interpreted of something's really going to happen wrong, just like the cognitive model of anxiety. And so the panic sort of rises. Typically panic attacks don't last, as they feel like they last forever when you're having one, but they typically last, like and it's really hard because, it's so subjective, but typically it should get to its peak. It shouldn't stay at its peak for more than about 20 minutes before it starts to come down generally, on average. A lot of people, it'll last for 5 minutes. Now, it'll take the rest of the day for people to really come back. Some people can shake it off, and other people will just need to go to sleep for the rest of the day. So it can be quite disruptive to functioning, if you imagine.
This video that is in the bottom of the slide with Millie, most likely to panic, is a really nice description of somebody who's dealing with panic disorder. And it also, if that web page, you go there and you're interested, she's really got some good, there's some good other videos sort of following her through her treatment and as she worked on exposure and other things. The thing about panic disorder is really disruptive. It does increase your risk for impulsivity because people are so uncomfortable. So we should always remember that everybody with anxiety disorder should be screened for suicidal ideation and previous attempts. And we should be thinking about safety with them as well as trying to comfort them. And what else was I going to say about panic disorder and anxiety? Oh, I can't remember. Highly treatable though. So please know that, like, these are terrible things to live with, but so treatable. And one of the things when I worked in primary care that really bothered me was seeing people who had waited so long to get treatment for a lot of reasons, lack of knowing that there's treatment available, where to get it, a lot of the stigma of not wanting to admit that this is happening to you. But yeah, I used to see probably 60 people a week with panic disorder when I worked in primary care. Like, it's common. And the most reassuring thing they hear is that they're not the only ones that suffer from it. So the more we can talk about it and show people how to get help and that it is treatable, the better it is. Next. So first, to respond to somebody who's having a panic attack, which we might see anywhere in our practice as a nurse, first thing to do is to calm yourself, because your anxiety will increase when you're around somebody with acute anxiety. And so you want to make sure that you're kind of grounding yourself. Because as soon as you're talking to somebody who's breathing fast and talking really fast and worrying or thinking about terrible things, you will get caught up in it. So it's really important to kind of just take a breath just for like a moment and pay attention to yourself, because you're going to notice you're going to have to pull yourself back from breathing faster and getting revved up. Step 2, you want to focus the patient on the here and now. I'm here. I can see you're really upset. I can try to help you. Can I try and help you? Get permission if you can. If they can focus on you, don't try and touch them without say, I'm going to put my hand on your shoulder. If you want, you can sort of say that. But if you sort of walk up to them and start rubbing their back, you can kind of freak them out. So it's a really good idea when you're working with anyone with anxiety to always try your best to tell them what's going to happen next and give them a little bit of choice in the matter. They're going to be hard. It's going to be hard for them to focus you. So you really want to get in sort of eye line with them. Don't talk to them necessarily from behind, because they won't be able to focus on you. But of course, always remembering safety of distance, just because people can react and start to run and push you out of the way or something like that. You kind of want to be in front to the side so you can step away or move away in your chair. You want to really just say, okay, first I want to take some breaths. You're going to direct them to breathe. Okay, so once you've got their attention, got their permission to help, I'm just going to give you some breaths. We're going to slow down your breathing. And they're going to be going like this as you say that. I can't. And you're going to go, yeah, okay. Now breathe in, 1, 2, 3, and breathe out, 1, 2, 3. And they're going to be going, I can't. And you're just going to keep doing it. Just try and catch them. Breathe in, 1, 2, 3. Good. And exhale, 1, 2, 3. Good. And just praise them, slowing down as you go. You can stay at the same pace, or you could be a little faster and then slow down, but don't try and go breathe in, breathe out, breathe in, breathe out to start where they're at, because that's just going to reinforce them. So less talk is more with anxiety, because the processing is slow. Usually you can do this at about 3 minutes. They start to slow down and follow you, and then just kind of say, okay, now. The other thing you can do is ground them to look at the floor. You may have seen this on the unit. So look at the floor. Do you see the floor? You feel your feet on the floor. What color is the floor? The floor is brown. The floor is white. Okay, the walls here. So focusing on the here and now will help ground them is the other thing. Step 3, skip ahead. Then you can start talking and find out what's going on. In other words, don't bother doing that until they're coming down and they're breathing and they're not feeling like they're going to pass out. So you need to give them time before you start going, tell me what's going on, because you don't want to do that when people are really in the full flight of panic. And so panic attack is not a time to be working on teaching deep breathing. It's not a time to be talking about cognitive reframing or that people, or positive self-talk or anything like that. It's just a time to ground people. That's all it is. And then when they come down, you can say, tell me what's been going on. Don't even assume and don't ask. Like, don't say, why are you so upset? Tell me what this means to you. And try and get a sense of what's been going on for them and how they're making sense of it. And you'll hear people with all or nothing catastrophic thinking. That's guaranteed you're going to hear that. But what you have to do is, and you can try, if you have some rapport, if you know the person, you can try and disrupt that a little bit. Say, okay, I hear you saying that every possible thing's gone wrong. I'm here right now, and I'm telling you that I can help you a little bit. Okay, so not everything's gone wrong. So just that little disruption, you're not completely alone. I'm here, kind of thing. And then you can start problem solving and seeing alternative possibilities if they have some. So that's usually for a situational stressor. Now, if somebody has panic disorder and they're just having these sort of random panic attacks because their wiring is going that way, basically you want to reassure them and go back to the cognitive strategies such as the panic diary and things like that. And that's about all I was going to tell you. Bye.